So good morning, everybody. It's my pleasure to introduce Dr. Andrea Wirsching. She is chief resident with us for a long time, also went to the United States and had some also clinical research time there. And she will talk today on the topic of benign hepatic lesions, benign liver tumors. And we will hear what is new at the front. Thank you.
So thank you very much. So we'll talk about benign hepatic lesions today. We'll start with describing the clinical presentation of those lesions. Then we will go to the histologic classification, have some insight into diagnostic modalities, indications for surgery, and there will be a take-home message on the most important points. So the clinical presentation of benign hepatic lesions is usually silent. So they are usually found incidentally on a CT scan or MRI done for other reasons, and the patients do not have any symptoms. Sometimes if the lesion is large enough, it has a mass effect. So for example, it has a right upper quadrant pain if there is a capsule stretch, or maybe it compresses the stomach with some nausea and early satiety. Pain due to hemorrhage and infarction can also take place in specific lesions. When we look at the histologic classification, we have different cells in the liver. So we have epithelial cells with our hepatocytes and biliary cells, and also mesenchymal cells, non-epithelial cells, which are, for example, vessels and adipocytes. Myocytes can also be in this group. When we look at hepatocytes, then we can have different lesions. The most common one is the focal nodular hyperplasia. We will hear later on about that. Then hepatocellular adenoma is another one, which is less frequently encountered, and focal fatty change is something else we will very quickly describe. Biliary cells can give rise to bile duct adenoma or biliary hamartoma, which is a benign lesion we will talk about later. And very common in the mesenchymal cells is hemangioma. It's the most frequently encountered lesion, benign lesion in the liver, and less frequent angiomyolipoma, lipoma, and myolipoma. When we talk about benign liver lesions, we always have to talk about diagnostics, and then we come to the radiology part. So the most important diagnostic is a contrast-enhanced MRI, sometimes a CT scan. And when we talk about contrast enhancement, we have to talk about the different phases of the contrast and how the lesions behave. There is the arterial phase. This is a phase, a CT scan or an MRI taken after about 35 minutes of contrast injection. And what we have there is an enhancement of hypervascular tumors and also hemangioma. Then the portal venous phase. This is a phase where the portal vein feeds the liver the best. And we can see there enhancing normal liver and hepatocytes, which are optimally seen. Equilibrium phase after about 10 minutes of contrast injection. This is a phase where also the veins, the hepatic outflow is enhanced. And here we can see lesions which have an early contrast washout, and also lesions which pool the contrast, like hemangiomas, or a retention of contrast in scar, which we have, for example, in the focal nodular hyperplasia in the middle, which have the central scar. We will start with the hepatocytes, and there with focal nodular hyperplasia. Focal nodular hyperplasia is a lesion thought to arise from abnormal vessels, which are feeding a part of the liver with enhanced arterial flow, and around this abnormal vasculature, hepatocytes start to proliferate in nodules. And those nodules usually are formed around the central scar, which contains the dystrophic artery, and also in a stellate form, dystrophic arteries are infiltrating this nodule in scar tissue. This is how it looks. It does not have any capsule, and hepatocytes are normal hepatocytes with no dysplasia. Usually it's a lesion encountered in women, so the women-to-men ratio is 9:1. It's about a prevalence of 1%, so for benign liver tumors it's quite frequently encountered. It is multiple in 20% of cases, and in 25% of cases it coincides with hemangioma, which is maybe also a hint towards the hypothesis that it arises from abnormal vasculature. And it does not show any growth on oral contraception or pregnancy. So this is something which is different compared to other benign liver lesions. and there is no risk going out from FNH. So when the diagnosis is made by radiology, which is a contrast-enhanced MRI, for example, shown below, with a typical arterial phase. It's a hypervascular tumor enhancing in the arterial phase. We can see it here. And then there is the central scar, which is hypo-intense, and then the hyper-intense central scar in the late phase. When we have this typical picture, we can stop following the patient and we can step back from surgery, because surgery in these patients is only indicated if there are clear symptoms, and if not, one can completely leave it alone. The next lesion we will talk about is hepatocellular adenoma. Hepatocellular adenoma is a very different entity. So they have there 4 types of histologic manifestations. So what we will talk about first is how it can look like histologically. There can be a hepatocellular adenoma which is steatotic. And in red, I already added the typical mutation found in this steatotic type. It's the hepatocyte nuclear factor 1 alpha inactivating mutation, which is associated with it. The next histologic subtype is the inflammatory or telangiectatic subtype of hepatocellular adenoma. This is very specific because there are dilated sinusoids at the rim of the lesion, at the periphery of the lesion. We also find scar tissue with arterioles in this specific lesion, and it also looks, we will see later on, a little bit different when we look at imaging. The next subtype histologically is hepatocellular adenoma with cellular atypias and also pseudoglandular formation. Those are already like histologically hepatocellular adenoma, which looks dysplastic, and it also is associated with a specific mutation in the beta-catenin gene, which we can hear later on more about. And unclassified hepatocellular adenomas are hepatocellular adenomas which do not show any of these specific features. Again, hepatocellular adenomas are more frequently encountered in women with a women-to-men ratio of, again, 9:1. It is not frequently encountered with a prevalence of 0.05, and it has been diagnosed more frequently after the onset of oral contraception use, which was in the 70s. So there is a clear correlation with oral contraception or androgen use and the formation of hepatocellular adenoma. Obesity and metabolic syndrome also have an impact on the formation of hepatocellular adenoma, as have specific metabolic diseases like the glycogen storage disease. Hepatocellular adenomas are important because they can have complications. So in 25% of cases, those lesions can lead to hemorrhage, and those lesions can also have malignant transformation. This is why we have to differentiate them from other benign lesions in order to plan the treatment. Unfortunately, those lesions can, unlike FNH, not be always diagnosed right away from radiology. So hepatocellular adenoma can very well mimic hepatocellular carcinoma, and only 2 subtypes allow a more clear discrimination to hepatocellular carcinoma. I showed them here. The first subtype is the telangiectatic or inflammatory type of hepatocellular adenoma, which has this dilated sinusoid at the rim of the lesion and also this arterioles, and all this different or vasculature can be seen in MRI. And what we see here in the picture above, this is the atoll sign. It's a rim around the lesion, which is hyper-enhancing in T2 weighted MRI sequences. T2 MRI sequences hyper-enhance water or fluid. And so this dilated sinusoids can be seen at the periphery of the lesion. And if we have a hepatocellular adenoma with this specific sign, we can say, oh, it can be this subtype, and we can be reassured. The other subtype is the steatotic hepatocellular adenoma subtype with the specific HNF1 alpha mutation. And this steatotic subtype can be diagnosed in specific MRI sequences, which are the in and the post-phase MRI sequences. Those sequences especially catch the steatotic part of the lesion. And what we see here in the darker part is the opposed phase, and the brighter part is the in phase of MRI sequence. And in the opposed phase, there is a signal drop in fatty lesions. So in the opposed phase, we would see this lesion hypo-intense and would know that there is a lesion with an increased content of steatosis. Unfortunately, the majority or the other hepatocellular adenomas cannot really be distinguished from hepatocellular carcinoma because they are hypervascular, they can have a portal venous washout. And so what we see here is a very useful tool, radiology assistant from the Netherlands. They very well describe radiologic features of different tumors. And we can see here that adenoma and hepatocellular carcinoma, they share different features in the imaging, and we cannot really distinguish them. And again, in the lower part, I mentioned that lipid accumulation is a sign for a more benign hepatocellular adenoma subtype. Hepatocellular adenomas more recently have been extensively looked at with sequencing. So different mutations in hepatocellular adenoma have been looked at and then correlated with the outcome. And we see here the publication from 2017, Nolte and colleagues at the group or many groups from France, which looked at about 500 hepatocellular adenomas, what for molecular signature they have and what the outcome was. And they distinguish now 8 different subtypes of hepatocellular adenoma. And they showed, for example, that the mutation in exon 3 of the beta-catenin gene is associated with more complications, with more malignant transformation. And for example, the exon 7 and 8 mutation, the beta-catenin gene, is rather associated with a more benign outcome. And again, they showed that the mutation in the hepatocyte, nuclear factor 1 alpha inactivating mutation, leads to the steatotic subtype, which has quite a good outcome and is seldomly malign, if not never. Here's a short put together the high risk and low risk groups we got to know here. So we see here that the high risk molecular subtypes and the low risk molecular subtypes, both, if they occur in man, have a high rate of malignant transformation, which leads to the hypothesis or to the recommendation to resect every hepatocellular adenoma in men. So there's a difference between female and men, and in men, every hepatocellular adenoma should be resected. And what we also can see here that in females, this hepatocellular nuclear factor 1 alpha mutated subtype had 0 malignant transformation. So there could also be a discrimination for this specific subtype in order to avoid surgery if not necessary. Again, taken together, the risk for malignancy in hepatocellular adenoma is male gender, then size above 5 centimeters. This is a cutoff which has already been introduced some years before and also has been reinforced by the publication we just have seen. Size above 5 centimeters is usually a cutoff to go for resection unless it is this very specific HNF1 alpha mutated subtype with the benign character. And any beta-catenin mutation has to be looked at closer. However, if the size is below 5 centimeters, the beta-catenin mutation per se should not lead to resection. Androgen use is another risk for malignant transformation. And if there is a malignant transformation, hepatocellular carcinoma arising from hepatocellular adenoma usually do not show any alpha fetoprotein increase in the serum. So one should not be on the safe side or feel on the safe side if there is no increase. Hepatic adenomatosis, this is a disease we're talking about if patients show 10 or more hepatocellular adenomas. They can be of different sizes, and they are not associated with an increased risk. And predominantly, it is the benign molecular subtype. And so for this, many lesions in one patient, we should follow the one lesion which is above 5 centimeters and maybe go for a resection on only this one lesion. Pregnancy has always been discussed because we know that hepatocellular adenoma, growth of hepatocellular adenoma is induced by oral contraception, and this hormones or increased hormone storm we also have in pregnancy. And so sometimes maybe people have advised against pregnancy in this patient, but the studies done so far, and this is one study from 2019, which followed about 50 patients who were pregnant and had hepatocellular adenomas, showed, yes, there is growth, but there is no risk for the woman or the child. In this 50 patients with hepatocellular adenoma, only one needed a transarterial embolization to stop the growth because it was already 7 centimeters, but everyone else had a good delivery and no baby was had any risk. So when we look at an algorithm, how to approach hepatocellular adenoma, we can maybe suggest this algorithm. First of all, look, is it a female or a male? If it's a male, go for resection. Then go for the size. Is it above 5 centimeters in a female? Then we can look at the MRI a little bit closer in an opposed phase. Is it a steatotic lesion? Then one could argue to do a biopsy. If it is indeed this very benign subtype with this HNF1 alpha mutation, then one could safely follow the patient. If not, go for resection. If it is below 5 centimeters, it is safe to go for follow-up imaging yearly or twice a year, and of course to stop oral contraception if it is in use. Transarterial embolization is not established for benign hepatic tumors, not for hepatocellular adenoma, not for FNH. However, there are some little retrospective series which have shown, for example, for FNH, there is an extensive size reduction with transarterial embolization, and a majority of patients improve in symptoms. And for hepatic adenoma, there are also some retrospective multicentric studies. One of them I show here, and transarterial embolization has been done primarily for size, sometimes for bleeding, less so for symptoms, and there is a size reduction of about 50% with hepatocellular adenoma. However, what is important, if a patient presents to the emergency department with a bleeding, with a hemorrhage due to hepatocellular adenoma, transarterial embolization would be the first choice in this patient. Looking at focal fatty change very quickly, this is just something we might take for a benign hepatic lesion, but it is only an accumulation of steatotic hepatocytes, mainly around the gallbladder on in segment 4, and has no risk and no impact. Looking at biliary cells very quickly, biliary cells can also give rise to benign tumors. We can have the von Mayenburg complex. Those are little biliary hematomas. They do not have any connection to the bile ducts, and they have this very impressive picture in the MRCP, which we can see here, this like sky-like looking appearance of the liver with little small nodules below 5 millimeters, which do not communicate with bile ducts. And biliary adenoma is also small, about 5 millimeters, subcapsular. For a long time, people have thought, okay, that's benign disease. However, recently with mutational analysis, one has shown that, okay, there are BRAF mutations in these lesions, maybe they can progress to cancer. Looking now at non-epithelial lesions, we can have a look at hemangioma. This is the most frequently encountered lesion, benign liver lesion, and it consists of clusters of blood-filled cavities lined with endothelial cells. So it's vessels in scar tissue. It is again more commonly encountered in female, 5:1 female to male ratio. Again, childbearing age where it is diagnosed. Prevalence is 3 to 20% in recent studies, and 45% show growth of about 5% or more during a lifetime. Above 10 centimeters, one hemangioma is considered to be giant, and those giant hematomas, who may also be pedunculated, they have an increased risk maybe to cause problems. Again, like in hepatocellular adenoma, there is a growth with pregnancy and oral contraception and also steroid use. So if possible, one should stop this medication in order to prevent growth. There is no risk with hemangioma in the liver. So even in big lesions, it is very rarely encountered that those lesions bleed or cause any trouble. What is troublesome and one should quickly look at is the Kasabach-Merritt syndrome. This is especially in very big hemangiomas when thrombocytes are trapped and fibrinolysis is induced in this big lesion. Then this can go to the system and also cause at the end a consumptive coagulopathy in the patient. And the therapy is to remove the hemangioma as fast as possible. The hemangioma also has a very specific and clear radiologic diagnosis. So one the very specific light bulb sign in the T2 weighted MRI sequence. This is T2. We can see it in the red box. Again, fluid is bright, and we can see this light bulb, which we do not have in other liver lesions, and this is the hemangioma. And when we look at the contrast behavior, we can see that the contrast filling starts at the periphery and goes to the centrum. So arterial phase has some periphery enhancement, and then it goes more and more to the central, this centropetal filling of contrast. It's again something very specific for this lesion. Therapy is again only resect if symptomatic. If there is no symptom, you don't need to follow this lesion necessarily, unless there's a pregnancy and it's already very big, you might follow it still. Again, transarterial embolization is not really a therapy of choice, but there has been documentation of size reduction. Other non-epithelial lesions, mesenchymal origin, angiomyolipoma, lipoma, they are less frequently encountered, also have their specific features in radiology. And angiomyolipoma, if it is there above 5 centimeters, should be biopsied because malignant transformation is possible. And in lipoma, one could leave it alone because there is no risk. So it's a take-home message very quickly. Contrast-enhanced MRI is the modality of choice to discriminate those lesions. FNH and hemangioma are benign, so don't touch them unless they're really clearly symptomatic. Hepatic adenoma, resect them always in males, and if they are above 5 centimeters in females, with this little exemption of the benign subtype with the HNF1 alpha mutation. And always with hemangioma and hepatic adenoma, stop oral contraception, but don't prohibit women to go for pregnancy. Thank you very much.
Yeah, thank you very much, Andrea. Very nice presentation of a very common disease. Just maybe a few words to, since you summarized that very well. I think now today compared to several years ago, we have the radiology. So very often we have, as we have shown, the diagnosis. Very few in this lesion should have a biopsy. For example, in hemangioma, and we see sometimes a biopsy could be a big problem. So very often we do have the diagnosis before. I also learned something, the FNH, 9 male for 1 female. I did not know that. Is that true? Is that autopsy series?
9 females for 1 male.
Yeah, is that correct?
That should be
I don't
correct.
know. Okay,
yeah.
I will check because that's new for me for the other one. Now, I think it's also very important to inform the patient. FNH is certainly the one we should almost never operate unless they are clearly symptomatic. Patient need also to be clearly informed about this because they may go, they worry, and they may find someone who will at the end operate these patients. And the combination is FNH with this, not much symptom, private insurance, private clinic, not only, and then they get these operations. I think it's important patient is informed in an important way. The taste, I think there is very little. I mean, the level of evidence is very low. I see no indication for transarterial except in an acute bleeding situation, etc. And that needs certainly to be seen also by a surgeon who has experience with this disease. Well, I mean, I think you summarized the adenoma is still something we operate most of the time, but indeed there is a few cases that need also to be discussed in million that doesn't require operations in some way. FNH probably never operated, and there is still a small numbers then you don't know. And then importantly is also the location. You do not have time, depending on where the tumor is in some time. Doesn't mean if it's a nice location you operate anyway, but that play a role in going or not for surgery for this adenoma or doubt of tumors. If it's located very difficult, then you may indeed do a biopsy and learn what that is. Otherwise, sometimes if it's a good location with minimal invasive, you can take it out. There's probably not much morbidity or problems that a biopsy, percutant biopsy is. I don't know if there's any questions or other comments
So Andrea, thank you very much for this comprehensive talk. I think you did a very well presentation. And I just want to frame it, nothing happens so much, right? So, except for the adenoma. So we go there more for a personalized approach today compared to when I was fellow. Every adenoma was considered almost the same except perhaps the metabolic diseases for glycogen storage disease. So very well done, and we would like to ask other people for questions.
Andrea, thank you very much for this very nice talk. This is indeed very interesting, this genetic profile of the adenoma. Is this something that is in common practice here in the hospital? Do do the whole profile in every adenoma, or is this done by individual cases?
They're good radiological differences. But honestly, if you want to do it, then you need a biopsy, right? So, and not biopsies are always taken, and as long as the diagnosis is done by MRI and the gender is clear, then I think then you make your judgment. Sometimes it becomes difficult if the lesions are undeterminable. Then, you know, you might have a biopsy and then you go for immunohistochemistry and all these other things. But I would say we are not at the level that every adenoma is sequenced today.
Is it sequenced when you take it out afterwards? Is there any role for sequencing?
Not yet, not complete sequencing, yeah. But I think the French people did it in their study. They had a large collection of adenomas and then they basically did the systematic sequencing. Other questions? I think then we can close. Thank you.